Okay, hello, my name is Lydia. Lydia Prichard-Ellis. I'm one of the sisters on AMU. I've been there for about 6 years now. And I'm here with Emma Welch, just talking about nurse-led discharges. As part of the 8 Days of Spring, we're trialling it on MAS, the Medical Assessment Zone, or the Assessment Zone. And it's part of the Clinical Vision of Flow work stream, just trialling these initiatives during this time. And Emma Welch is here with me.
It's really nice to be here with you this morning to talk about this. I think it's a really interesting initiative. And yes, I'm Emma. I'm one of the Deputy Directors of Nursing and Quality within medicine, and my realm of responsibility is unscheduled care, which obviously covers the assessment zone. So why don't you start off by letting us know what nurse-led discharge is?
Yeah, so the way we're looking at it in the minute, and I think what other hospitals seem to have done when they've implemented it, is that we would ideally get someone who, so a nurse who's appropriately trained, competent, and so we're kind of looking at more senior band 5, senior band 6s, who would take the responsibility of discharging patients who kind of meet pre-agreed clinical criteria.
Okay.
So we've got at the moment a clinical criteria for discharge, so it would be very clear parameters within that. And if the nurse then assesses the patient and they feel that they meet that criteria, then they would be able to discharge that patient, and they need to make sure the relevant paperwork, etc., is all completed.
So is this something you would be expecting the consultant or registrar to do on their ward round and board round, and set you real clear ideas of, if temperature less than or certain blood results are around, give you real clear parameters the nurses can go in and go, right, yeah, tick, tick, that meets those parameters, and they can then don't need to bother the doctors again?
That is pretty much exactly it.
Yeah.
So an example we were using the other day was that if, let's say, a patient's on oxygen and they need to be weaned off the oxygen, they need physio and OT to review prior to going home, that it would be that the reg or consultant, they would document that that would be the clinical criteria for discharge, that they're weaned off their oxygen and that they can mobilise or they're at their baseline. And if those things are okay, we're asking as well that they do document quite clearly that it is appropriate for a nurse-led discharge, so that we're happy that there's a senior review has happened and that they are happy that a nurse does lead the final discharge. So it's things like that. The aim is, so in MAS at the moment, we're finding that our discharges are happening later on in the day, so kind of between 1 and 6 we're finding is when 1 and 6 p.m. is when we're finding a majority of our discharges are happening. And what we're looking to do is to kind of get them back even a few hours, so before midday. And so what we've been saying is, even if the reg or consultant can identify someone who's probably going to go home the next day, is that they would identify that, and then we would ask then the junior to complete the relevant paperwork in preparation, and then it would all be ready and teed up for the next day.
That's fantastic, because bearing in mind the assessment zone on AMU is sort of supposed to be a minimum of 12 to 24 hour period. So that looking ahead as well, so you're planning those things the day before. Also improves the speed in which we can work and get the patients out sooner, along with the criteria-led discharge. Could you just describe a little bit of what that MAS is?
So MAS is a 12-bedded area, so it looks at, so it is an assessment area, and we get our synapsis patients, so GP referrals come through. We do get patients coming as well, sometimes from, so when they come from Cheltenham ED, they need further reviews, assessments, etc. And sometimes we do get some from outpatient clinics who become unwell, or their bloods are abnormal, etc., and they do need someone to just review them. So we get them from various places, but majority are synapsis GP referrals.
And it's going to be useful for us to trial as well, because we do have a senior consultant present there most of the day. So you're going to get that criteria-led decisions on a consistent basis.
That's exactly it.
So the nurses can do it consistently as well.
So
what's the benefit for our patients then? So the patients that are coming in and we're going to be managing them in this way, what are they going to get out of this?
So, well, I mean, length of stay is one thing. So, I mean, patients who are sat waiting to be discharged home. From personal experience, I know that it's not very nice for them, when they've been told that you can probably go home, but they've got no clear kind of plan in place, or they're not, things haven't been communicated with them. They can, I completely understand, because I'd probably be exactly the same. Is you want to know what's going on, you want to know what's happening, what is the plan from here. So I think definitely the waiting times for our patients, and as well, not only that, is when they are discharged, that they have a clear plan in place. And you find that hospitals who have trialled this already have found that the readmission rates actually from nurse-led discharges tend to go down. I think it was like 30-40%.
Wow.
So not insignificant.
That's good.
And it's because that patient has a clear plan in place, and they also have an idea of their post discharge care and what they need to do to make sure they don't come back in. And so say for instance you need to go to your GP and get your bloods done within this amount of time, making SDEC appointments, making sure they're aware of where they need to be and what time and things like that. So yeah, definitely that for them.
It's also quite empowering for the nursing team, isn't it?
Yeah.
But also for the benefit of the patients that are in the emergency department, that are a source for you to pull through.
Yeah.
That would happen quicker.
Yes, yeah.
And also it reduces the amount of time patients are waiting to be seen, doesn't it, by the clinicians, because they're free to do that whilst you're dealing with actually getting the patient sorted to go home.
Yeah, and as well on that, when I was saying about, a lot of our discharges happen later on in the day, so between 1 and 6, actually that tends to be when a lot of our admissions come in as well. Yeah. So if we get the discharges done much earlier, then we've got that capacity to be able to deal with those new admissions and just give them all of our time.
Absolutely.
Rather than trying to deal with discharges and admissions at the same time. It frees up the nurses and the doctors, because sometimes when people come in, they're quite poorly and they do need a review quite quickly, and so it frees up the doctor to be able to do that and have space to do that as well, because that was an issue we were finding in MAS, is that sometimes because we're waiting for patients to be discharged, we're waiting for that final blood result to be reviewed by a doctor. That does slow things down, and it means that people are waiting in our corridor waiting to be seen by a doctor. So you're absolutely right, it will speed things up.
Can you think of any benefits for our staff as well? Because they're a very busy crew working on the assessment zone and AMU. So how's it going to improve their working life? As
I just said, with having space to actually see people and not having that pressure of, I'm trying to discharge a patient, but also I've got this poorly patient here that I need to be seen, but I need to make a bed to see them in, so therefore I need to discharge this person first. It just gives you that time to actually look at the patient as they're coming in, not be worrying about the discharges you need to do, and you have a space to see them. You're able to do the ECG, their bloods, their OBS. You're able to get a doctor to come and see them. They've got somewhere to see them. So that, but also from a nursing point of view, it would be quite empowering for our nurses to be able to have the ability to make those, build up their confidence in making those clinical decisions, in assessing the patients based on the criteria for discharge. At the start, we've said that it will be senior band 5s and senior band 6s. We will see how it goes. Yeah. And then if it works and does well, and we've got a clear plan in place of how we're going to proceed with it, then we will start training our more junior band 5s in how to discharge patients safely.
Because those more experienced nurses are going to be more competent and confident to do that. Yeah. And you don't want that pressure of discharge on the junior nurses, because they're still finding their feet. Yeah. So, OK, we're doing this on the assessment zone, and that's great because it's going to be a real benefit, I feel, to that area. But when do you think we're going to be able to trial that or move that out more widely around other places? So,
I mean, we've given ourselves about 6 months to trial it on MAS, and if it works and does well, we've said about 30-40% to get our discharges before midday, and if that does well, then we would look at rolling it out across AMU. And Andy Andovan, who's acute medical consultant, he's lead for the clinical vision of flow. We've discussed that with him, and he's quite on board with that as well. So we've got support as well from senior consultants.
And I do think a great next step to that is then moving on to the other base wards, because to then improve the flow from AMU even more out into those areas, if they can get their discharges earlier, once we've maybe worked out the wrinkles of this, and kind of then can pass it on as like a working structure, that will bring the ward patients out sooner and move their discharges early, which will release AMU patients sooner. So I think it's a great thing to work through on AMU, and then hopefully I can facilitate that with my counterpart within scheduled care, Alex, and look at maybe trialling it on some of the other medical-based wards.
That is what we would really like to do.
Yeah.
I think it would work really well. And other hospital, there was a hospital, I think it's West Midlands, and they've done it, and across their whole hospital, they've done it on the wards and AMUs and short stay areas. They've done it in ED as well, and I think it was something again like 40% increase in how quick their discharges are done, or decrease, in the delay for discharge is 40%.
And I think that's a real positive.
Yeah, definitely.
So let's keep our fingers crossed.
Yeah, hopefully. Yeah.
Fantastic.